Yes, Rohit, how much time?
I think we should.
Sir, we are live, good to go.
We're already live?
Yes, sir.
Uh-huh. Okay, so very good evening. We all are living in some country of some of the continent of this earth, and then which is in again a part of the solar system, which is again somewhere in this galaxy. So when we look from the perspective of the whole universe, we know that it is very difficult, or we are almost invisible. But invisibility does not mean non-existence. What better than the current times will really vouch for this statement that invisibility does not mean non-existence? This particular dreadful virus, that is COVID, has really put huge impact on the whole globe, starting whether it is India or whatever country it is. It has in fact changed the whole world, and the world now, people are started looking the world as if one part which was before COVID, that was BC, another part which is AD, or I would say AC, which is after COVID. We don't know how the things are going to fall. Some people are trying to look towards the astrology, some people are trying to decipher the prophecy of some of the people like Nostradamus. So we have multiple theories which are in place, but when we look to all these theories, what is common in everything? The thing which is common is that we all have a hope that one day we will be seeing the light through this dark tunnel, the hope that we will be able to detect this particular infection at a very fast rate, in a very fast, in sooner time, the hope that we will be having a perfect treatment for this particular infection, the hope that we will be having a vaccine with 100% chance of prevention of this particular infection. Do you know where this hope comes from? This hope actually comes from two hands which are coming out of white sleeves. Yes, you all are the hope for this whole globe or for the whole humanity. So at the outset, I would like to salute all of you for providing this selfless support to the whole society, to the whole humankind, so that they can enjoy this healthy as well as prosperous and happy life. We know that for life, what is most important? We need water, air, food, everything. In the same way, when it comes to a treating clinician or a physician, a very important thing is knowledge. So today we sit here in this era to basically understand and update ourselves with the newer avenues in various aspects of diseases. But there is, like the COVID pandemic, we have an infodemic right now. So we don't, a lot many informations are coming. The most important thing is to have proper prospect, the correct person to hear, and the correct thing to be taken up by us. So with this background, I, Dr. Amit Jain from Medical Affairs Department, INTAS, on behalf of Viva D Division, welcome all of you on this today's international speaker program on osteoporosis management in renal patients. In this, we have a wonderful panel in which we have international speaker with us, that is Dr. Michael Macklem. Welcome you, sir. Dr. Macklem is founding director of Oregon Osteoporosis Center, Portland. He is internationally recognized. He is internationally recognized expert in the field of osteoporosis and bone density testing. He serves as a member of Council of Scientific Advisories for International Osteoporosis Foundation, on Scientific Advisory Board of the National Osteoporosis Foundation, and he is a medical advisor for Paget Foundation as well. He was a member of WHO Fracture Risk Task Force and has led to the development of the FRAX tool. He has also served on Endocrinology and Metabolism Advisory Committee of the FDA, and he has multiple publications, more than 200 papers and book chapters as author, as well as the co-editor. He is also a co-editor for the book for clinicians about disorders of bone and mineral metabolism. So I feel really proud and happy to welcome you, sir. Then we have a wonderful panel in which we have today moderator is Dr. Vijay Kher sir, who is chairperson and division of nephrology and renal transplant medicine at Medanta Hospital, Delhi. So without taking too much of time, I would like to hand over the session to Dr. Vijay Kher sir so that he can take the sessions further. Over to you, sir.
Thank you, Amit. Welcome all of you to this webinar, and it's a pleasure to welcome Michael McClung, who is an expert in osteoporosis, and in addition, we have two great panelists who are going to join Dr. Michael McClung in the panel discussion and take up the question and discussion with us. And one is Dr. Subhash Wanganu. He is an senior consultant and a very experienced endocrinologist, and he's an expert also in his interests have been diabetes as well as bone mineral density and osteoporosis. And we will gain from his large experience on this, Dr. Wangnu. Welcome, Dr. Wangnu. And then we have Dr. Tanupal. He is a double whammy. He is a rheumatologist and he is also a nephrologist. And he's an associate professor at the SSKM hospital in Calcutta. So welcome, Dr. Tanupal. And these both panelists will join us in the panel discussion with Dr. Michael McClung. Dr. Michael McClung, welcome to this webinar, and I will request you to begin your talk. Welcome.
Thank you very much. It's been it's a great pleasure to be a part of this discussion today, and to take advantage of the technology that's so badly necessary in this unusual time here. So let me share my screen and slides to begin. So as mentioned, I am an endocrinologist, but have had an interest and focus on osteoporosis for many years. And today we're going to address the issue of managing osteoporosis in patients with impaired renal function. And let me attempt to update us all on what we know about that. As you're aware, the kidney is very important in the management and regulation of mineral metabolism. In recent years, it's been appreciated that a decrease in renal mass that occurs with impaired renal function, either due to disease or to aging, results in increased circulating levels of an interesting regulatory protein, FGF23. And FGF23 has two roles. One, it inhibits the development and synthesis of calcitriol, the active form of vitamin D, and it also impairs phosphate excretion, resulting in hyperphosphatemia. And the hyperphosphatemia leads to a further decrease in calcitriol synthesis. Those effects result in the development of hypocalcemia and an increase in parathyroid hormone synthesis, resulting in a state of secondary hyperparathyroidism. In situations where vitamin D deficiency predominates, then a state of osteomalacia can be the prominent abnormality in the skeleton in these patients. And so the regulation of calcium in the setting of impaired renal function is both complex and important from a clinical standpoint. As a result, it's not surprising that significant abnormalities in mineral metabolism occur in almost all patients who develop severe renal impairment. And there are special forms of metabolic bone diseases that characterize patients, particularly those who are on dialysis. Collectively, those bone diseases are known as renal osteodystrophy, and images, bone biopsy images of the four recognized types of renal osteodystrophy are shown here. Of these, hyperparathyroid bone disease, or osteitis fibrosa, is typically the most common encountered. Osteomalacia is relatively rare because of the appropriate use of active vitamin D metabolites like calcitriol, although in the early days of renal bone disease, osteomalacia predominated. There are also patients who have a mixture of hyperparathyroid bone disease and osteomalacia. And then lastly, I think the most serious form of renal osteodystrophy is, as you know, called adynamic bone disease, where bone metabolism is markedly impaired. Patients develop stress fractures and bone pain, and we've had very little understanding about how best to treat that problem. But those are the forms of bone diseases that occur in patients on long-term dialysis. Those are different from osteoporosis. But it is possible, of course, to have these bone diseases and osteoporosis mixed together. The primary approaches to managing the metabolic bone diseases associated with chronic kidney disease are to ensure adequate levels of the active forms of vitamin D and to control parathyroid hormone secretion with either medications like cinacalcet or, in some patients, with surgery to reduce parathyroid mass. For patients who have osteoporosis or a history of fractures, these strategies for managing renal osteodystrophy are not enough to manage the osteoporosis component. In younger patients with renal disease, osteoporosis rarely occurs because, as you know, osteoporosis is a chronic disorder that occurs gradually over many, many years and is most commonly seen in older adults. We can diagnose osteoporosis in patients with, like without renal failure by the same criteria. Bone density measurement by DEXA. The results are described as standard deviation units called a T-score, and osteoporosis is diagnosed when the bone density value in the spine or the hip has a T-score of -2.5 or lower. The clinical diagnosis of osteoporosis is made if a patient presents with a non-traumatic hip or spine fracture or a history of multiple other fragility fractures. And it's clear that these criteria are applicable in states of impaired renal function as they are in patients with normal renal function. Two of the causes of renal osteodystrophy, both osteomalacia and hyperparathyroidism, can cause low bone density, and that confounds the diagnosis of osteoporosis. So while everyone with osteoporosis, or almost all people, will have low bone density, not everyone with low bone density has osteoporosis. And that's important to consider and to remember, because osteoporosis drugs would not be indicated in patients with renal osteodystrophy characterized primarily by osteomalacia. The treatment there, of course, is to replace vitamin D and particularly active forms of vitamin D. Hyperparathyroid bone disease in the setting of renal failure is best managed by lowering PTH, again, either with cinacalcet or with surgery, while many of our osteoporosis drugs will reduce the high bone remodeling that is seen in patients with hyperparathyroidism. That can result in improved bone density, but they also cause an increase in parathyroid hormone, and some of the extraskeletal as well as the osteoitis fibrosa part of the problem is not managed appropriately with those drugs. So we have to consider osteoporosis on the background of renal osteodystrophy in many of these patients. And of course, because anti-remodeling drugs like bisphosphonates and denosumab that we'll talk about are potent inhibitors of bone turnover, they should be used with caution in patients with or at risk of adynamic bone disease. Most of you are familiar with the fact that there are 4 categories of drugs that are routinely used for the management of patients with osteoporosis. Those include raloxifene, an estrogen antagonist. It has a weak estrogen-like effect in the skeleton. Bisphosphonates, that we'll talk about in more detail. Denosumab, a human monoclonal antibody that blocks the activity of rank ligand, that again we'll describe in more detail. And then lastly, a bioactive form of parathyroid hormone called teriparatide that has a very different mechanism of action. In the review of management of patients with osteoporosis in the setting of renal insufficiency, the expert panel called the Kidney Disease Improving Global Outcomes panel reviewed all of the information and recommended that the treatment of patients in that the treatment of osteoporosis in patients with CKD 2 and CKD stage 3 with higher normal PTH levels should be the same as we use in patients with normal renal function. That's because several studies in patients with CKD stages 2 and 3 have shown the expected increases in bone density with osteoporosis drugs and similar reductions in fracture risk as we see in patients with normal renal functions with no special untoward adverse events in CKD stages 2 and 3. For patients with more severe renal dysfunction, there are no general recommendations, but therapy has to be individualized depending upon a whole variety of other parameters and what we can discern and understand about their underlying renal function and forms of metabolic bone disease. And there is very little information about the use of osteoporosis drugs in patients on dialysis. Some of that I will attempt to share with you later. Let me think with you about what we know about the use of each of the categories of drugs in the management of patients with CKD. Raloxifene, of all the drugs we have, is the weakest inhibitor of bone resorption. In women with postmenopausal osteoporosis, raloxifene reduces the risk of spine fractures, but not of other fractures. So it's not recommended for treatment of osteoporosis in patients at high risk of fracture. In the large study with raloxifene, a subgroup analysis was performed in women who had CKD stages 2 and 3, and the effects of raloxifene on both bone density and fracture risk were similar in that subgroup with impaired renal function as compared to the patients with normal renal function. There's one small study that I found in which raloxifene was administered to a small number of patients on dialysis. There were very small and transient reductions in markers of bone metabolism, but the values returned to normal even while raloxifene therapy was continued. There was a very small effect of raloxifene on bone density and minimal effect on serum PTH, consistent with the weakness with which raloxifene impairs bone metabolism. So I would not consider raloxifene to be a useful management of patients with osteoporosis in the setting of renal insufficiency, except perhaps as the last resort. There's been many, many more studies about bisphosphonates. Bisphosphonates have a unique pharmacology. They bind very tightly to the skeleton where they inhibit osteoclast activity and bone resorption, but they also inhibit bone formation. Bisphosphonates are not metabolized. They are cleared by the kidney. Because of their tight binding to the skeleton, they have a long residence time in bone even after treatment is stopped, with circulating levels being observed for several years after bisphosphonate discontinuation. There's concern about the use of bisphosphonates in patients with impaired renal function because early studies of zoledronate in patients with cancer administered very high doses, and that induced cases of acute tubular necrosis. The nephrotoxicity of zoledronate was related to the Cmax of the drug, not to the total dose, so that rapid infusion of a large dose was what was associated with renal dysfunction. Because of that history, patients with impaired renal function were excluded from participation in the large trials with oral bisphosphonates. That then led to the caution about the use of oral bisphosphonates in patients with impaired renal function. However, oral bisphosphonates are very, very poorly absorbed, and it's almost impossible to generate a high Cmax of the drug when given by the oral route. And there is very little evidence that the use of oral bisphosphonates has a significant adverse effect on renal function. But again, because patients with impaired renal function were excluded from the pivotal fracture trials, the regulatory language suggests that these oral bisphosphonates be used with caution in patients with impaired renal function. In women with postmenopausal osteoporosis, bisphosphonates are very effective in reducing the risk of vertebral, non-vertebral, and hip fracture. Again, studies have shown that the effect of bisphosphonates in patients with CKD stages 2 and 3 are the same as in normal renal function. And in those patients, no dose adjustment or difference in treatment needs to be considered. In those patients who were enrolled in the pivotal trials with impaired renal function, including a few with CKD stage 4, no particular safety issue has been identified with oral bisphosphonates. In CDK stage 4, zoledronate has been used successfully in my clinic and in other clinics around the world if the infusion time is extended from the usual 15 minutes once a year up to 1 or 2 hours. That provides the same dose of the drug, but of course limits the Cmax of the drug. And when administered that way, we have not observed problems with intravenous zoledronate therapy in patients with CKD 3 and 4. Paul Miller, a colleague here in the United States, who is also a nephrologist and a bone expert, recommends that after the loading dose of either oral or IV bisphosphonates, that then the dose be reduced by half because of the renal clearance and the long residence time in bone. There have been some very small short-term studies with alendronate in dialysis patients. Those studies have shown very modest effect on bone density, but no particular safety concerns. Bisphosphonates, by inhibiting bone resorption, can induce hypocalcemia, and that is a particular risk in patients with vitamin D deficiency. And so bisphosphonates, like other anti-remodeling drugs, should always be co-administered with calcitriol and adequate intakes of calcium in patients with renal impairment. Because of the concern about adynamic bone disease and oversuppression of bone turnover, extra caution about the use of bisphosphonates should be a part of our thinking in patients with low bone turnover states. We can clinically identify those patients by those who have low levels of serum bone alkaline phosphatase or relatively low levels of serum parathyroid hormone, levels less than 100 milligrams, 100 picograms per mil. The unique drug in treating osteoporosis is teriparatide, again, a bioactive form of parathyroid hormone. In postmenopausal osteoporosis, teriparatide reduces both vertebral and non-vertebral fracture risk. We don't have evidence documenting hip fracture risk reduction. In, again, the pivotal studies with teriparatide in women who had CKD stages 2 and 3, the effects on bone density and both vertebral and non-vertebral fracture risk were similar to what we saw with normal renal function. In a very small Japanese study, teriparatide was given to patients with CKD stage 4 and stage 5, only 3 patients in the latter category. The patients were treated for 2 years. Increases in serum P1NP, a marker of bone formation, were noted. So the bone forming effect of teriparatide was still observed, and lumbar spine bone density also increased without significant safety issues. I think this is an important study because many of us have conjectured that because parathyroid hormone levels are high in patients with end-stage renal disease that administering more parathyroid hormone would not have an effect on bone metabolism. But it appears that that might not be true. But again, this is only a very small study, and more information about the role or the use of teriparatide in renal disease would be welcome. That then brings us to denosumab, which would be the major focus of the discussion. Denosumab, as I mentioned, is a fully human antibody that binds to and inactivates a growth factor called rank ligand. Rank ligand is produced by osteoblasts and osteocytes that binds to a receptor called rank on osteoclast precursors. That interaction of rank ligand with its receptor rank is required for the activation, proliferation, and differentiation of osteoclast. Without that interaction, osteoclast activity and bone resorption simply don't happen. There is a natural inhibitor of rank ligand called osteoprotogerin, or OPG, which is a soluble decoy receptor that binds rank and limits its activity, a normal governor of that process. Denosumab, by being an antibody that specifically binds to and inactivates rank ligand, acts like OPG by inhibiting rank ligand's effect on bone resorption. The cartoon makes this clearer. Here are osteoblasts secreting the green dots of rank ligand. Rank ligand binds to receptors on the surface of pre-osteoclast that then results in the differentiation to an active bone resorbing osteoclast. OPG is also synthesized by osteoblasts, binds to and modulates the activity in the local environment of rank ligand. So the rank ligand OPG ratio is what determines the rate of bone resorption. After menopause in women and with aging in both men and women, there is a gradual increase in rank ligand production, and so that rank ligand predominates. That's the explanation for the increased bone resorption seen after menopause in women. When denosumab is administered, it also binds rank ligand and limits or prohibits the interaction of rank ligand with its receptor, and as a result, osteoclasts simply, or active osteoclasts, are simply not made, and bone resorption is inhibited. The pharmacodynamics and pharmacokinetics of denosumab are shown here. Shown in blue is the serum level of denosumab after a subcutaneous dose of 60 milligrams. Maximal serum levels are reached at between 1 and 2 months, and then the values gradually fall back to pre-treatment levels before the next dose, and exactly the same pattern again is seen. We've now followed patients for out to 10 years with exactly the same pattern happening dose after dose. In response to those doses of denosumab, there's a very prompt and dramatic reduction in indices of bone resorption. So shown in yellow are serum concentrations of CTX, a marker of bone resorption. Within 3 days, that value is reduced by 85%. The low point is reached about 1 month after the dose, and then over the course of the time before the next dose, given at 6 months, there's a gradual partial offset of the effect on bone remodeling. And again, we've followed patients out to 10 years with the same boringly repetitive pattern of response to denosumab. There is no evidence that patients develop immunologic or other forms of resistance to denosumab therapy. Based on these studies, the dose that's used for denosumab is a dose of 60 milligrams given subcutaneously once every 6 months. Denosumab, like other antibodies, is metabolized by the reticuloendothelial system. There is no renal clearance, and denosumab is not nephrotoxic. So no dose adjustment is necessary in patients depending upon their renal function. And unlike bisphosphonates, where there's caution recommended in use in patients with renal insufficiency, there is no contraindication to the use of denosumab in patients with impaired renal function. The contraindications include hypocalcemia that should be evaluated, corrected before denosumab should be used, and of course pregnancy and being hypersensitive to denosumab or to other immunoglobulin therapy. This looks again at the effect of denosumab therapy on serum CTX levels, what we've seen before, marked reduction, nadir at 1 month, gradual offset, and then the next dose, the same pattern happens. In contrast, when alendronate is given in the head-to-head study that we published many years ago, there is a gradual decrease in serum CTX that then remains constantly low with ongoing weekly treatment with alendronate. The level of bone resorption assessed by CTX in patients who receive denosumab comes back to the level seen with alendronate at the 6-month time point. So denosumab is a more potent inhibitor of bone turnover, but that effect on bone turnover is fully reversible as denosumab is cleared from the serum. The study that led to the approval of denosumab for the treatment of osteoporosis was the FREEDOM study. At the time, the largest osteoporosis study ever done. 7,808 women were enrolled in a study and were randomly assigned to receive either denosumab 60 milligrams every 6 months or placebo, followed for 3 years with fracture risk reduction as the primary endpoint. After 3 years, it was noted that compared to placebo, there was a 68% reduction in the incidence of new vertebral fracture, a 20% reduction in the incidence of non-vertebral fracture, and a 40% reduction in the risk of hip fracture. Fracture risk reduction in the spine and hip were seen as early as 12 months after beginning therapy. And as we'll talk about later, that fracture protection persists at least out to 10 years, as long as we have followed patients on denosumab. In the clinical trials, denosumab was very well tolerated, no increased risk of adverse or serious adverse events compared to the placebo group. There were a statistically increased number of patients with skin rash or cellulitis, although very small numbers in both groups. These were generally mild and cases that did not result in substantial problems. Numerically, there were more patients who developed malignancy or infections in the denosumab group, although these differences were not statistically significant. This was important because rank ligand is expressed in small amounts in dendritic cells of the immune system, and there was then a theoretical concern that denosumab would result in impaired immune function. We have looked for and been unable to demonstrate any evidence of impaired immune function in response to denosumab, and there was no signal of opportunistic infections or unusual immunologic malignancies in this study. No effects on cardiovascular or renal function were noted. There were fewer deaths in the denosumab group compared to the placebo group, no immunologic resistance, and no adverse impact on fracture healing. There were several studies have been performed comparing the effectiveness of denosumab with bisphosphonates. Those are the two categories of drugs that we most commonly consider as treatments for osteoporosis. In a study of 590 women with osteoporosis who had not previously been treated, women were randomly assigned to receive alendronate or denosumab, were followed for a year, and in both the hip and the spine, the increases with denosumab were greater than were seen with alendronate. Similarly, in patients who had been previously treated with bisphosphonates for at least 2 years who were randomly assigned to receive either denosumab or zoledronate, the increases in bone density were greater with denosumab than were seen with the IV dose of zoledronate. In a similar study, women who had been on bisphosphonates for at least 6 months, the average duration of treatment was 3 years. The women were randomly assigned to receive either alendronate or denosumab, and again, the bone density response to denosumab was greater than was seen in women on alendronate. Another study was designed to compare denosumab and alendronate with regard to compliance and adherence to therapy. So women with osteoporosis were enrolled in a study, randomly assigned to receive either denosumab or alendronate during the first year. At the end of that year, the treatments were switched. So patients were crossed over from denosumab to alendronate or from alendronate to denosumab. All this was done blindly to both the investigators and to the patients. The primary endpoint was the rate of adherence to therapy between the two treatment groups. And those data are shown here. Shown in blue is the fall off in adherence rates in the women who received alendronate. So even in the setting of a clinical trial, adherence fell by about 25% over the first year of the study, whereas the compliance with denosumab, of course, was much better. Then, after crossover therapy, during the second year, compliance with alendronate was even worse in women who had previously been treated with denosumab, suggesting that with longer-term bisphosphonate therapy, compliance becomes worse and worse over time, and that compliance then is better with a drug that's given infrequently and administered by a healthcare provider, as is denosumab. In a review of data from the United States Medicare population, modeling and a measurement of adherence with all of the osteoporosis drugs were done. And as shown here, the persistence and compliance with denosumab in this study were better than with all of the oral agents, and even better than teriparatide, where patients self-administer the drug subcutaneously once daily. Appreciating that osteoporosis is a chronic problem that is not cured with therapy, as we planned the FREEDOM study, we built in a long-term extension. We wanted to know what the effectiveness of treatment would be over a long time and what the safety would be. It would have been ideal, of course, to have continued the placebo group for a long time, but it was deemed unethical to have patients with osteoporosis be in a study on placebo for a long time. So the study design was that for 3 years, there was the placebo-controlled arm, and then the women who completed that phase of the study were then enrolled in the extension for an additional 7 years, during which time all women received open-label denosumab therapy. Over that 10-year time, the effect of denosumab on vertebral fracture risk remained stable, shown here in green as the annual incidence of vertebral fractures in the placebo group during the 3 years of the placebo-controlled trial, compared to the 68% overall reduction with denosumab. And then during the extension study, those lower rates of vertebral fracture risk persisted. Shown on the right is the annual incidence of non-vertebral fractures in the FREEDOM and extension study, demonstrating the 20% reduction compared to placebo during the first 3 years. And then, interestingly and uniquely, a gradual persistent reduction in non-vertebral fracture over the remaining 7 years of study. And that relationship between lower rates of non-vertebral fracture with increasing duration of therapy was a statistically significant finding. Further analysis of the Freedom Extension study made clearer that that long-term therapy was associated with a lower incidence of non-vertebral fracture. Dr. Ferrari and his colleagues compared the rate of non-vertebral fracture during the first 3 years of exposure to denosumab. That includes the patients who were randomized to denosumab during the first 3 years of Freedom, but also includes the women who were in the crossover group who received placebo during Freedom, but then started denosumab in the extension. And so those two groups, the experience during their first 3 years of exposure were pooled. Then for the women who had received denosumab during the first 3 years of Freedom, but then who took denosumab for an additional 7 years, the rate of non-vertebral fracture after the first 3 years was substantially lower than it had been during the first 3 years. And similarly, in the crossover group, non-vertebral fracture risk after 3 years was lower than during the first 3 years. No other drug has shown this effect, where the fracture risk protection improved with long duration of therapy. The bone density responses to denosumab over the full 10 years of therapy are quite dramatic. In the lumbar spine, over 10 years, a 21.7% increase from baseline was noted in the women who took denosumab continuously for 10 years. In the group that received placebo for 3 years and who then began denosumab, similar large increases were seen. In the total hip, although the increment is smaller, the pattern is similar, with continuous progressive increases in bone density over the full 10 years of study. Improving bone density, of course, is not the primary objective of treating patients with osteoporosis. The objective is to reduce the risk of fracture. So why do we dwell on the bone density change? Firstly, the change with long-term denosumab therapy is very different from what we see with long-term bisphosphonate therapy, where with bisphosphonates, values go up for 4 or 5 years, but then plateau and stay steady even with long-term therapy. In the Freedom trial, total hip bone density measurements were measured in every patient every year. So over the full 10 years of the study, there were almost 100,000 individual total hip bone density measurements made. We also then, of course, knew whether the patient experienced a fracture the year following each of those total hip bone density measurements. And so an analysis was done comparing the total hip T-score level achieved on treatment with what the risk of non-vertebral fracture over the subsequent year was in this entire population of patients. And what we see is an association. The higher the hip bone density achieved on therapy was, the lower the incidence of non-vertebral fracture. This pattern is exactly like we see in untreated patients, where we have known for many years that bone density is a strong predictor of fracture risk. But this is the first time we've ever shown that on treatment, bone density correlates with current fracture risk. A similar finding was seen in a different clinical trial comparing romosozumab, a totally different drug, and alendronate. So suggesting that this is a common feature and that using bone density in response to treatment as a marker of effectiveness is warranted. That idea is further strengthened by a meta-regression analysis performed by the Foundation for the NIH, published in our Bone Journal last year. This group looked at 38 placebo-controlled fracture endpoint trials with 19 different therapeutic agents involving more than 110,000 subjects and many fractures, and correlated the percent increase in total hip bone density with both vertebral fracture risk and with hip fracture risk. So they demonstrated that the studies and drugs that induced the greatest increase in hip bone density were those associated with the greatest reduction in either vertebral or hip fractures, suggesting and demonstrating that there is a relationship between how effective drugs increase bone density and how effective they are in reducing fracture risk. Over the 10 years of denosumab therapy, there was no new adverse event noted. The annualized rate of adverse events, including infections and malignancies, remains stable over the long-term therapies. Similarly, serious adverse events, including infections associated with hospitalization, remain stable and steady over the full 10 years of therapy with denosumab. We mentioned that denosumab is not excreted or metabolized by the kidney. There was a single dose study looking at the administration and pharmacokinetics of denosumab in patients with dialysis. And what's shown is that irrespective of level of renal function, that the PK of denosumab was not affected. The incidence of hypocalcemia was related to the degree of renal impairment. There were slightly more cases of hypocalcemia in patients with markedly impaired renal function, and more importantly, the magnitude and the duration of hypocalcemia was longer, it was greater and longer in patients with more markedly impaired renal function. Importantly, in this study, for the first half of the study, patients were not given supplemental calcium or vitamin D. And once supplemental vitamin D was co-administered with denosumab, the incidence of hypocalcemia was substantially reduced. In the FREEDOM trial, a subgroup analysis was performed looking at the effect of denosumab on both bone density and vertebral fracture risk as it correlated with the renal function in the patients. So patients were divided into the CDK categories. There were 78 patients with CDK stage 4, more than 2,800 with CDK stage 3. Not surprisingly, the patients with more markedly impaired renal function were older, had higher serum creatinines, and had lower bone density values. Over the course of the study, hypocalcemia was very rarely observed in the FREEDOM study. But in that study, patients with vitamin D deficiency had been excluded, and everyone received supplements of calcium and vitamin D. Shown on the right are the vertebral fracture data in the subgroups of renal insufficiency, the placebo rate shown in yellow, the denosumab rate shown in blue, and again, across the entire spectrum of renal function, the effect of denosumab on vertebral fracture risk reduction was similar, suggesting that in patients, at least with moderately impaired renal function, denosumab was effective in both improving bone density and decreasing fracture risk. There have been very small studies of denosumab in dialysis patients. In a Japanese study, 324 patients received denosumab for 12 months. That means 2 doses. 121 were on hemodialysis. The other 203 had a markedly impaired renal function, but were not yet on dialysis. Large increases in bone density were seen, as shown in the right. The prevalence of hypocalcemia was higher in the hemodialysis patients than in the non-dialysis patients, and the median time to develop hypocalcemia was 7 days in the dialysis patients. Interestingly, there was a correlation between rates of bone turnover as assessed by a marker of bone resorption TRAP5B. Also, hypocalcemia was more common in patients who were receiving glucocorticoids or in those without calcium supplements, although even in patients with calcium supplements and calcitriol treatment, hypocalcemia still was observed, but to a lower extent. Other studies have also documented increases in bone density with denosumab in patients on dialysis, especially in those with intense secondary hyperparathyroidism. In those patients, bone pain is improved. The elevated serum alkaline phosphatase as a marker of high bone turnover is reduced, suggesting that the high bone turnover state is made to be more normal with denosumab therapy. But serum PTH levels go up, often quite dramatically, after the first dose, and then gradually fall back toward baseline by 6 to 12 months. In dialysis patients, hypocalcemia has been reported in as many as 42% of them, usually occurring, as we've said, 4 to 8 days after the first dose, but may occur as late as 3 or even 4 weeks after that first dose. Most of these cases are asymptomatic, but sometimes severe hypocalcemia lasting several weeks, requiring long-term intravenous calcium infusion can be seen, especially in patients with inadequate calcitriol therapy. And as I've emphasized, that risk of hypocalcemia can be minimized with calcitriol and calcium supplements given both before and during denosumab therapy. The effects of hypocalcemia or the need to treat it with IV calcium therapy on the vascular complications of renal insufficiency have not been evaluated. One other important point about denosumab in terms of its pharmacology is that as soon as denosumab is cleared from the serum, the effect of denosumab on inhibiting bone turnover goes away. In the phase 2 study, we've treated patients for 2 years, then discontinued therapy, and within 3 months, the inhibition of bone resorption was gone. Then there was a rebound in markers of bone remodeling, and that led to a rapid loss of all of the bone density that had been achieved on therapy, with values returning to baseline within a year after stopping therapy. We also know that the protection from vertebral fracture is lost within a few months after discontinuing denosumab therapy, and that then requires that if denosumab therapy is stopped, that follow-on therapy with a drug to inhibit the rebound in bone remodeling and the increased rate of bone loss has to be considered. And the only drugs we have that we know do that effectively are bisphosphonates. So we have studied both teriparatide and raloxifene after stopping denosumab. They are not effective in preventing the rebound in bone remodeling. Shown in the top panel on the right are studies we did in that compliance study I mentioned before, where patients were given alendronate for 1 year, and the spine and hip bone density are shown in the green bars. Then they were transitioned to alendronate, and the bone density values remain stable. Other studies have demonstrated that giving 1 dose of zoledronate 6 months after the last dose of denosumab prevents bone loss in most, but not all patients upon discontinuing denosumab. Unfortunately, the follow-on therapy with bisphosphonates after stopping denosumab has not yet been evaluated in patients with markedly impaired renal function. So to summarize what we know about managing osteoporosis in patients with chronic kidney disease, that managing the metabolic bone diseases and renal osteodystrophy is a very important part of managing patients with chronic renal failure. In those patients who also have osteoporosis, in addition to their renal osteodystrophy, considering osteoporosis management becomes important as well. as we've stated several times, for patients with CKD stages 2 and 3 with mild to moderate impairment in renal function, we treat their osteoporosis just like we would in patients with normal renal function. But treating patients with more severely impaired renal function, especially in those on dialysis, must be individualized and monitored very carefully. And again, while we've evaluated small numbers of patients on dialysis with osteoporosis drugs, none of those studies have been large enough to demonstrate that osteoporosis drug therapy in dialysis patients effectively protects them from fracture. Of the drugs available to treat osteoporosis in patients with impaired renal function, denosumab is by far the most effective anti-remodeling drug we have. It has much better hip fracture protection data than we have with teriparatide and has better adherence to therapy than with other drugs. I'll mention again that follow-on therapy with a bisphosphonate is required if and when denosumab therapy is discontinued. For patients with mild to moderate renal impairment, denosumab therapy, in my opinion, is the treatment of choice for their osteoporosis. For patients with severe renal impairment, including those on dialysis, denosumab can improve bone density and decrease bone pain, and treating those patients with denosumab would be most appropriate for patients that we have ruled out low turnover bone disease and osteomalacia, either by bone biopsy, which is done rarely in my country, and I assume rarely in your country, but we can use biochemical parameters to identify those patients with low bone turnover. And then lastly, adequate intakes of calcium, vitamin D, and active forms of vitamin D are very important to use in patients with end-stage renal disease, both before and during osteoporosis therapy. After denosumab, it would be important to monitor serum calcium for the first 4 weeks after the first dose, and then that would not be necessary to do after subsequent doses unless the patient had developed hypocalcemia after the first dose. The benefits of denosumab in patients on dialysis that we know: improving bone density, reducing bone pain, hopefully reducing fracture risk, have to be weighed against the risk of hypocalcemia and the theoretical risk of adynamic bone disease in patients on dialysis. And as you make the decision to begin denosumab in a patient with markedly impaired renal function, remember that the end game might require you're considering the use of a bisphosphonate if or when denosumab therapy is discontinued. With that, I'll conclude the presentation. I thank you very much for your attention, and I very much look forward to the discussion with the other panel members. Thank you very much.
Thank you, Michael, for that wonderful overview of management of osteoporosis in patients with renal impairment. And I think that was really exhaustive and very informative, And I'm sure there are going to be questions because, as you said in your talk, that the number of patients with renal impairment that have been studied with osteoporosis, especially with advanced renal failure, has been minimal. And as you said, that patients up to stage 3 kidney disease can be treated. Osteoporotic patients with stage 3 disease, up to that period of time, they can be treated the same way as with general osteoporosis. But patients with stage 4 and 5 CKD, patients are going to be the ones where you might need clinical decision making and need to monitor and look at these patients more carefully before you make a decision about treating these patients. I'm sure that is going to come up in discussion as well. And I will now turn over to our panelists from India and try to see what are the experiences of these two panelists who are fairly experienced in treating bone disease and osteoporosis in general population as well as in patients of chronic kidney disease. And may I go to Dr. Subhash Wangnu? Dr. Wangnu?
Yeah, I'm able to hear you, but some problem with the camera, but I'm able to hear you.
Okay, so can you just tell us, tell the audience as well, that what is your experience about
Not able to hear. Not able to hear. Dr. Kher. Something went wrong. Dr. Kher, not able to hear.
Yep, he appears to be frozen. So while the technicians are helping revive him, share with us your experience and perspective again about managing bone disease in patients with severely impaired renal function.
Yes, as far as the India is concerned, as an endocrinologist, what is my experience? Normally, I always spend some time explaining and discussing the treatment options for osteoporosis in these patients of chronic kidney disease. Sometimes it becomes very difficult to convince them to start the treatment for something which they think is asymptomatic without any much symptoms. So what I prefer in my clinical practice as an endocrinologist, up to CKD stage 3, I am happy and safe to use the bisphosphonate and teriparatide and also the denosumab even up to the stage 3. And right now, quite often now, we have started using frequently denosumab because of the compliance and because of this impact on the fragility factor, both vertebral and non-vertebral, and also the long-term impact of the denosumab. And even if the patient stop it, as you already told, that we always supplement with the dose of bisphosphonate, particularly zoledronate. Now coming to the stage 4, I only prefer the denosumab, not the bisphosphonate because of some inherent issues. And you already told that in the general population, if the patient is in CKD5 or 5D, that is dialysis, there is no dependable data exists to guide therapy. And it should be probably be reserved for patients who have already suffered and survived a fracture and are therefore at high risk of death from a second event. And one thing I have observed in my practice that prolonged severe hyperparathyroidism in CKD, if the PTH is more than 600, and the bone turnover marker in terms of bone specific alkaline phosphatase is more than 25, what I suspect that the patient is suffering from severe secondary hyperparathyroidism, and sometimes we are able to locate a small adenoma in during the radiological investigation, and we do advise in this patient to undergo parathyroidectomy because the endocrinologist will tell them whether it is a tertiary hyperparathyroidism leading to the formation of a small adenoma. And then we do advise parathyroid where we are able to typically localize a small adenoma in severe hyperparathyroidism. Usually PTH levels are almost more than 600. But even after parathyroidectomy, because the PTH is low, I prefer to continue the denosumab in these patients of this severe hyperparathyroidism. But in my practice, as an endocrinologist, we are also using calcium mimetics. And these calcium mimetics we do in patients who are having the moderate elevation of PTH between 120 to say around 600, not less than 600, with a normal or low calcium and no liver disease. And these patients sometimes can be controlled very well with the use of calcium mimetic, the cinacalcet. And I have seen its use in this particular subset of the patients, a very good response to the cinacalcet. And if the patient does not respond and the PTH, even after the reduction of the PTH, patient's bone density does not improve, then I continue and add the denosumab in these patients. In patients who are having mild hyperparathyroidism less than 120 with a normal calcium and or with a low calcium, I look for the presence of the looser zones in the pelvis and the femur and see whether the patient is having some clinical stigmata or the radiological feature of the osteomalacia. And then these patients we treat as simple with the vitamin D supplementations and the calcium supplementation. That is our routine as endocrinologists. We do work in close with our nephrology colleague, and we have a huge department on nephrology and endocrinology. The bone density are done frequently in our patients because it is freely available. And the for last 3 decades, we are using the bone density in our CKD patients. So this is my view as an endocrinologist and what we do in our setup.
Hello.
Yeah.
Can you hear me?
Now I can hear you.
Yeah, actually, I think I lost connection somewhere in between, and I don't know. So I couldn't hear you, but I think can we have Dr. Atanupal to give his experience about osteoporosis in general and in patients with chronic kidney disease?
Yes, sir. Being a rheumatologist as well as a nephrologist, because I have a unique opportunity to work in both the department since last 10 years. I have experiences with dealing with the osteoporosis in the rheumatology populations, where actually the people are much more exposed to corticosteroids, especially because of the treatment of rheumatoid arthritis, long-term low-dose steroid, or systemic lupus erythematosus SLE treatment because of the low-dose steroid, sometimes with the high-dose steroid. The patients come to us with sometimes avascular necrosis of different parts of the joints like hip, or mostly because of the vertebral fracture and the non-vertebral fracture. So in rheumatology practice, it is quite evident that the patient comes to us with the fracture, and when we go for the DEXA scan, we find that the patient is suffering from moderate to severe osteoporosis. Means even we find quite often that the T-score goes below -4 in several patients. So in that case, it is very easy to pick up the osteoporosis. But there are routine practice in our rheumatology clinic to ask for BMD DEXA in patients who are actually on regular treatment with us, whether it may be rheumatoid arthritis or SLE or other rheumatological diseases. So in that case, we quite often pick up the osteoporosis quite often, and we start treatment. Our practice is to treat with the supplementation with the calcium, vitamin D, if there is a deficiency of the vitamin D, and after that we start with specifically the zoledronic acid when it started available in our hospital. That is and the compliance is also very good with the use of this zoledronic acid. Yearly single dose is very the compliance is very good, and we usually give for 3 to 5 years, and after that we check BMD after 2 years or so, and quite often we find that the patients are stable. And here comes a problem of education as well as compliance, especially the middle class people or the lower socioeconomic population, where we find that the patients sometimes miss the follow-up, and sometimes after say 3 years or 4 years, patients landed up with fracture in different parts of the body, especially the vertebral fracture and the hip fracture. So again, we start giving the bisphosphonates and with other therapy. For the last 2 to 3 years, we are using denosumab very frequently in our population, and we are getting a very good results with the very good compliance. Here comes again the problem of the high cost of therapy, especially in the population or country like India. So sometimes we get supply of medicines free of cost from the hospital, and so the compliance rate is getting very high. So and few of the patients we are actually having denosumab therapy followed by zoledronic acid, that already discussed by Dr. McLung. So with this rheumatology population, the therapy, the diagnosing of osteoporosis followed by therapy is not very difficult. But what I find very difficult is picking up osteoporosis in the CKD population, especially CKD in stage 4, more than 3, that is stage 4, 5, as well as in stage CKD who are on dialysis, and even in post-transplant populations. So this is very difficult, because in nephrology population, especially the nephrologists are not very much keen to identify osteoporosis if not compelled by fracture or other things. The DEXA is very rarely advised by the nephrologist, as it is very common in either endocrinologist or with the rheumatologist. So in nephrology clinic, we have started writing DEXA for the last 3 or 4 years, and but not so high as rheumatology practice or endocrinology practice. Now it is very difficult to identify this osteoporosis purely when the patient is having CKD stage 4 or more, or patient is on dialysis. Here comes a very important thing, that in CKD population, we are having 3 components. One is the biochemical alterations, like lowering in the calcium level or lowering in the vitamin D level, high alkaline phosphatase level or so. We get bone quality changes in the form of BMD changes, like low T score. Or another important, very important, is the extra skeletal changes that we actually find in extravascular, means the vascular calcification. That is the more important cause for mortality in CKD population, that is the cardiovascular mortality, and that actually occurs in patients where the patient is suffering from adenemic bone disease. So here our most important concern, specifically in case of dialysis patient, is the to prevent the adenemic bone disease. So since 2012, the KDIGO has already recommended to go for the DEXA scan and to treat the osteoporosis. If the patient is having osteoporosis, to treat that. But before that, we have to be very much sure that the patient is already supplemented with adequate calcium, with vitamin D, and the phosphate levels should be in the normal range. If the hyperphosphatemia is there, the calcium binder, either calcium containing phosphate binder or calcium not containing phosphate binder, we should use to keep the phosphate level in the in the normal range. That is very, very important. Next thing is that the KDIGO has already indicated that to treat hypocalcemia, if after supplementation of the vitamin D, the calcium level is not coming up, then to treat with the normal level of calcium level. After that, if the calcium level is not coming up, then go for active form of vitamin D, that is the calcitriol. Because the earlier studies since 2003 to 2012, lots of studies have shown that with the use of active form of vitamin D, that is calcitriol, we are having much more evidences of adenemic bone disease. That means more chances of getting the extra skeletal complications in terms of vascular calcification and cardiac morbidity, mortality. Now the use of calcitriol is in a very specific subset of population. So that calcitriol we actually use in specifically the children where the growth is a predominant concern, where supplementation with the normal vitamin D, that is 25 hydroxy vitamin D, is not actually quite sufficient. Then we actually add calcitriol to make the calcium level normal in some populations. So in after that, after supplementations with the calcium, vitamin D, and phosphate control, then we start treating osteoporosis with specifically in this current situations, the denosumab for the last 2 years. And but the use of this denosumab is also very less in the CKD population in nephrology practice. This is in nutshell the experience of my practice in nephrology as well as in rheumatology, with the use of with the detection and the therapeutic challenges in nephrology and rheumatology.
Thank
So,
you, Dr.
yes.
Paul, for that wonderful overview of especially management of bone mineral disease in patients of chronic kidney disease, because that's an aspect which sort of complicates the diagnosis of osteoporosis in patients of chronic kidney disease. And see, till up to 2017, when KDIGO, which Dr. Michael talked about, uh, had not advocated use of DEXA scan for diagnosis of, because they felt the 2009 CKD BMD guidelines did not recommend a DEXA scan for diagnosing osteoporosis in patients of chronic kidney disease, because they felt that that wasn't a good method of diagnosing osteoporosis. But in 2017, when they looked at more greater evidence during the last decade or so, they found that probably using a DEXA scan, and that's the reason why what you emphasized is that nephrologists do not use DEXA scan as frequently, because this was not recommended by the experts in the field, at least till 2017. It's only during the last 2 to 3 years that nephrologists have started using DEXA scan and then diagnosing osteoporosis. And with the availability of denosumab now, which can be used in patients with advanced kidney disease as well. So now people have started sort of looking at osteoporosis in a real manner in the CKD population. And I would go back to Michael about two questions which I have, and I want his perspective on that. And you raise some of the perspective, and that's in patients who are on corticosteroids, and especially patients when they get transplanted, they continue to have maybe some osteoporosis added on to by corticosteroids, as well as persistent bone disease, which might be persistent in many of these patients, despite kidney function normalizing after the transplantation, but they get a different kind of bone disease. So what is his perspective about treating or management of specifically corticosteroid-induced osteoporosis, and how does one prevent it? Because many patients with chronic kidney disease, and I'm sure that's going to be a question from the audience as well, that many patients with chronic kidney disease may have had been treated with corticosteroids because of the immune-mediated glomerulonephritis and other causes for that. And what is your take on that? And the second is, how strong do you feel will the diagnosis of osteoporosis be made in stage 4, stage 5 disease with DEXA scan? Is there any tricks of the trade that you can tell the nephrologist as to what should be they should be looking for, and how careful they should be, and what are the things they should be looking for?
Sure. Let me deal with the second question first, because it relates again to the previous discussion. So, as you pointed out, in the 2009 KDIGO guidelines, there was not yet evidence or experience with looking at DEXA in patients with chronic renal failure. But since then, a variety of studies have shown that DEXA is as predictive of fracture in patients with CKD 4 and 5 as it is in regular patients. And so we should use DEXA in the same way as we do in normal patients. It is true that osteomalacia can present as low bone density. So in patients with severely impaired renal function, evaluating their vitamin D status, both by measuring serum calcitriol levels, appreciating and understanding what high levels of serum PTH mean, evaluating them clinically, as Dr. Wangu said, with ready grafts looking for looser zones or looking for bone tenderness, which is a feature of osteomalacia, but not of osteoporosis. All of those things go into that decision. So DEXA is very useful in patients with severely impaired renal function, but we need to think about osteomalacia and to rule that out. And before we get to even thinking about treating osteoporosis, all of the other components of the abnormalities of vitamin D and parathyroid and phosphate levels need to be addressed and optimized first. Then, if the patient if we feel the patient still has osteoporosis, only after optimization of all of the other facets of mineral metabolism do we then proceed forward with osteoporosis treatment. The questions about glucocorticoids comes in two parts. The easier part is in patients who have not been on glucocorticoids until their renal transplant. And of course, with new approaches to immunotherapy, the doses of glucocorticoids used after transplant are not nearly so high as they were 10 years ago. But it is true that patients who have a renal transplant very often experience bone loss, often rapid bone loss, and that can be easily prevented by either bisphosphonates or denosumab. The interval during which rapid bone loss happens is quite short. It's only in the first year or two. And so I personally feel that bisphosphonate therapy in those patients is probably the ideal therapy. While denosumab would work, 2 or 3 years after you begin their therapy, now you're faced with stopping denosumab, and then you have to consider transition to bisphosphonates. You can avoid all that confusion by using bisphosphonates in the first place. It's a different story about patients with immunologic renal disease like lupus, or who are on glucocorticoids before they develop renal failure. And there, bisphosphonates and denosumab are useful, but teriparatide is probably the best treatment for patients without severely impaired renal function who are receiving high doses of glucocorticoids. The study that Dr. Sag and others published in the New England Journal many years ago demonstrated that teriparatide was superior to alendronate in treating those patients.
So, Michael, this is my experience also that we treat with teriparatide in glucocorticoid-induced osteoporosis in our setup. That is our first choice. You are right. And also, as an endocrinologist, apart from the whatever you are told, we look for the nutritional status of the patient in the CKD. We look for the hypogonadism. We look for the hyperprolactinemia as an associated factor which might be responsible for the development of the osteoporosis apart from the steroid intake or the other drugs. So as an endocrinologist, we do really assess the patient on these lines also. What is your opinion?
You're exactly right. And that's what I meant, I think, by individualizing treatment in patients with severe renal disease. We don't treat osteoporosis, we treat patients who have osteoporosis and impaired kidney function. And so the factors that can contribute to bone disease are numerous and complex, and it requires, I think, a specialist who understands all of that to do a thorough evaluation and then to make the right choices about treatment. As was said earlier, treating patients with CKD stages 2 and 3 is easy and doesn't require, I think, specialist involvement. But once patients have more severely impaired renal function, it's a much more complicated story and requires expertise in knowing exactly how to do that.
Thank you.
So, in just looking at the questions that have come in, let me address one that very importantly, that's timely. The question was about in this era of COVID and worrying about immunity, do we need to worry about the use of denosumab and impaired immune function? I alluded to the fact that there was a theoretical concern that denosumab might impair immune function, but we knew that from the beginning of even the phase 2 study. We have looked very, very hard and very carefully and very extensively, and we find no serologic, laboratory, or clinical evidence that there is any impairment of immune function with denosumab. In patients with rheumatologic diseases who are also receiving biologic immune suppressors, there is no increased risk of infection or other problems when denosumab is added compared to when osteoporosis is treated with zoledronate, for example. So the concern about denosumab and immune function was a theoretical one for which we have no evidence of reality. So I think that we don't have to be overly cautious or concerned about that aspect of things in the current COVID-19 environment.
Michael, there is a question that Dr. Bhavakar is asking, that how do you identify patients of chronic kidney disease who are unlikely to have a fracture from those who are very likely to have a fracture with CKD, bone disease, as well as maybe osteoporosis? So would you use some scoring system, say FRAX, which is used by some people, and what would be your advice to before you start treating this patient?
Well, again, it's a question that's hard to answer. That's why it was asked, of course. We never get asked easy questions in these panels. So there is no perfect way to do that. So FRAX does not take into account the additional fracture risk that is seen in patients with chronic renal failure. However, the FRAX tool does give us at least relative differences in fracture risk among individual patients. So we've already mentioned that DEXA is a useful tool. If a patient has osteoporosis, that already puts them into a high-risk category. Certainly, if a patient has had a previous fracture, that would automatically put them into a high-risk category. And so I would rely on bone density and a history of fracture risk as the two most important clinical determinants of fracture risk and deciding when when treatment for osteoporosis would be considered.
I think what I use FRAX in my practice is just to have an assessment of the future risk of the major bone fracture in CKD patients, just for the assessment, not only for the diagnosis and the treatment protocol, what we have to see, just to tell them that this is a fracture FRAX score and that you are prone to develop major bone fracture in near future. Your opinion?
That's useful, but FRAX likely underestimates fracture risk in CKD patients, just because of the additional skeletal fragility and problems that patients with severe CKD have.
Up to CKD 1 to 4, it is okay, but not beyond 4 and the patient on dialysis.
Sir.
Fair enough. Fair enough.
Sir, another thing very important is that high turnover bone disease. Okay, we will target the PTH level. To target the PTH level 2 to 6 times of the upper limit of the normal, sometimes 9 times. But considering, so osteoporosis treatment to reduce the high turnover bone disease to normal turnover bone disease. So to supplement with the calcium, to vitamin D and phosphate control. But considering the adynamic bone disease, supplementing all others, including vitamin D and etc. Though if we consider treating, then we are having two options. One is Teriparatide, the metabolic, and another is the Denosumab. So with these two drugs, which would we prefer, Dr. McLean? Your choice.
So in patients who have low turnover bone disease, I would favor teriparatide over denosumab. I'm anxious about inducing adynamic bone disease. That has not been documented, but theoretically, if we're worried about inducing adynamic bone disease, a good way to do it is to take a potent anti-remodeling drug. So there, again, there's so little evidence that we have to sort of base our opinions on what we understand about physiology and pharmacology rather than on clinical experience. But as I mentioned, for patients with high turnover bone disease, after optimizing their calcitriol and calcium intake, I'm very comfortable using denosumab. For patients with low turnover disease, I would be more cautious about the use of either bisphosphonates or denosumab.
Yes. There is another question, Dr. Michael, and that's that this is from Dr. Sohail, and he says that the orthopedic surgeons feel that denosumab makes the bones stronger, but increases the risk of fractures, actually. Would you think that is there any evidence for that kind of feeling, or?
I think there is not evidence for that feeling. That, of course, we're aware of the relationship between long-term bisphosphonate therapy and atypical fractures of the femur and other bones. Two patients had femoral shaft fractures that met the criteria for atypical radiographic features in the Freedom trial with a very low incidence. Neither of those atypical fractures that met the ASB-MAR criteria felt like the bisphosphonate related fractures. Neither were bilateral, neither had prodromal symptoms, neither had periosteal thickening. Femoral shaft fractures with atypical features are a normal part of osteoporosis. So there's no clear evidence that denosumab induces or increases the risk of atypical fracture. We know from the Freedom trial that, if anything, fracture risk goes down with long-term therapy, not up. And a very careful analysis of the patients who did have fractures in the Freedom trial by the late Dr. Adami showed, if anything, showed clearly that there was no impairment of fracture healing or any difficulty in patients who had experienced fractures. So it's clear that denosumab improves bone strength, but I'm not aware of any evidence that denosumab increases the likelihood of fractures, including atypical fracture.
Yes. Another question is there a low calcium level where you would not use denosumab, or before you would raise the calcium level to what levels?
I'd be very cautious about the use of any anti-remodeling drug in patients who had an adjusted serum calcium that was below the normal range. And because calcium will fall when denosumab is given, even in calcium replete individuals. So if the value is already low, the chance of inducing symptomatic hypocalcemia becomes greater.
Yes. And when would you check for hypocalcemia? What would be the ideal time after giving denosumab? Would you do it after 1 week or 2 weeks?
I would do it weekly for the first month.
Okay.
There's no point in, there's no need to do it before 1 week, but one week is the low time. But particularly for patients on dialysis, after the first dose of denosumab, I would measure calcium weekly for 4 weeks. If serious hypocalcemia was not seen, then I would not do that routinely after the next doses of denosumab, unless something had changed.
Another question, just Subhash, one other question is that, is there any effect on vascular calcification with denosumab?
Yeah, we don't know. There's so few patients studied. I mentioned that I'm not aware of any direct effect of denosumab on vascular calcification. We saw no evidence of any kind of cardiovascular disease in the long-term Freedom trial. And in the patients, the small patients, number of patients on dialysis, no one has evaluated whether there's benefit or harm to the vascular or soft tissue calcification.
Subhash?
Yeah, I was telling that in our patient, when we start denosumab, we are sure that we are not dealing with the patient who is not on any calcium supplementation or is on very inadequate calcium supplementation. See, we do start with the adequate calcium supplementation as per the international guidelines, along with vitamin D when we start the denosumab as the first dose. And the protocol says we follow the patient not in the first week. We follow the patient after 2 weeks and after 4 weeks initially, whether the patient is stabilized or not. This is our protocol, what we follow.
Okay. There's one more question, and that's about protein energy wasting, which is very common in patients of chronic kidney disease, and especially in our country. So is there a concern using denosumab in patients who may have protein energy wasting? Michael?
Let me defer to you who have experience with that in India. I'm not aware of.
Actually, although this does exist in our CKD population, protein energy malnutrition, and that's basically because prior to the dialysis initiation, many of these patients on extremely low protein diets, Indian diets are as such also low protein. And on top of this, once they develop chronic kidney disease, they go further lower on protein intake, and it becomes really protein energy waste by the time they come on dialysis, and that's a problem in many of our patients. But I haven't found, usually many patients on dialysis do gain. I haven't personally faced any problem of protein energy, unless Dr. Tanupal, do you have any comments on this?
Yes, sir. Yes, sir. We are lots of patients having very lean and thin, having very low in nutrition status, and having say around if 32 years old male on dialysis with nutritionally poor status, having bilateral hip fracture. Another patient is we are dealing with currently is around 36 years old female, just pregnancy induced eclampsia followed by CKD for the next 6 months, and after that the patient's having severe malnutrition and having a fracture, again right hip fracture. These are actually nutritional status of the patients are very important in this aspect, because when patient is on dialysis, we need to supplement more of the adequate calorie, that is 30 to 35 kilocalorie per kg per day, as well as the high protein supplementation, that is 1.2 to 1.5 gram per kg per day we need to supplement. But the reality and the practical scenario are actually discordant in actually our population. So we are getting regular patients having fragility fracture along with poor nutrition in our population, and this is very much challenging to treat all these patients.
Vijay, I just want to make one comment. When we are talking about the bone mineral density on DEXA scan, we sometimes forget to educate our colleagues about the utility of the Z-score on the DEXA scan. And we know that reference database is also important in the assessment of the osteoporosis when in the patients of the what you call the premenopausal age group. And we have a race-adjusted Z-scores to define low BMD for the chronological age. I think this should also be kept in mind, the utility of the Z-score. I think Michael can give a comment upon whether he is using Z-score or not.
No, I think that's an important comment, and again, as you pointed out, it's particularly useful in younger patients. I don't find the Z-score helpful in older adults in the management of usual patients with osteoporosis.
In the younger age group, yes.
In the younger age group, I think it has a special role, and of course, Z-scores and T-scores follow each other quite closely in young people, but understanding that a Z-score compares that patient's bone density to what one would expect and anticipate in a person of that race, gender, and age allows us to communicate more clearly to the patient that we understand that they have a skeletal problem.
should we have a database gender specific also?
Sure, it needs to be gender specific, but because men in general, of course, have about a 10 or 15% higher bone density value. So T-scores and Z-scores are always based on gender-specific databases.
Because the men have large bones, naturally the DEXA is dependent upon the size of the bone. They might be having higher bone mineral density as compared to the females.
Sure, right.
Yeah, I think we are past about 10 minutes past 9. I think there are some more questions, but most of the questions have predominantly been answered by the panelists, and I must say that all good things must come to an end. And I think we have to say thank you, Michael, for a wonderful lecture, as well as taking up all those questions and giving us a very good perspective of management of osteoporosis in patients of chronic kidney disease. I must also thank Dr. Wangnu and Dr. Paul for participating in the webinar and giving an Indian perspective of osteoporosis. And I must thank all the participants for participating. And I must thank INTAS for providing us this opportunity to have Michael share his views about osteoporosis. Thank you, Michael, and have a good day. Thank you all. Bye-bye.
Okay.
Thank you very much, Michael.
Thank you.
Nice to see you and nice to hear you.
Well,
Thank you.
I
Thank
very
you.
much appreciated being a part of this. Okay.
Thank you.
Thank you
Okay.
so much, sir. As we come towards the end of today's discussion, as Dr. McLean told very correctly that there is no single best therapy option for managing any particular case. We need to individualize each and every patient for the choosing upon the best therapy which can be done for that particular patient. So yes, I agree that with all yours experience, sharing the experience by all of you would definitely help all the delegates who have attended today's webinar to make the best decision for their patients so as to ultimately obviously treat the osteoporosis and prevent the fractures. So as we come towards the end, I would like to invite Mr. Saurabh Gambhir, who is head of marketing and sales from Viva division, which basically caters to nephrology division in India from INTAS. To Mr. Saurabh, please.
So thanks a lot, Dr. Amit, and I would like to thank all the panel members for being a part of this program. And like Dr. Amit said, like I'm from part of sales and marketing. I've come at the last to thank you all, and hopefully we are doing a good job in terms of educating everyone. We hope that Dr. Michael's presence was helpful for everyone, and I thank Dr. Vijay Kher, Dr. Wangnu, Dr. Ratanu, and Dr. Michael for being part of this program this evening and very early morning for you, sir, in Portland. And thanks a lot for coming in and helping us out with this program. Thanks a lot, Dr. Amit, as well, for coordinating everything and getting all of us on the same platform. Thanks a lot.
Thank you.
Thank you so much.
Thank you, sir.
Okay.